Hi there, Mark Owen Cooper here. I'm at the National Rural Health Conference in Blenheim, and today I have Bruce Arroll with me, who is a Professor of General Practice at University of Auckland and Director of the Goodfellow Unit.
Thanks for having me.
Yeah, no worries. So I understand tomorrow you're doing a talk on, I guess, views and perspectives on depression and anxiety in general practice.
Yeah, rethinking depression and anxiety. Yeah, so there's really three parts I'm going to be looking at. The first is what we call the distress that we see every day in general practice. You can call it depression and anxiety, but they're sort of specific diagnoses and big labels. And as Alan Francis, the American psychiatrist, says, you're often seeing patients on the worst day of their lives. So why would you give them a big label? Why don't you let time, let the passage of time see what happens to them? Because, you know, we all have the worst day of our lives and they get a bit better from that. And the problem is if you give a label, and they're often wrong, in one sense, they go with the patient for the rest of their life. And I'll talk about this patient who came to look at adopting a child. And she's a 23-year-old woman wanting to adopt she and a partner wanting to adopt a child. And I look back in the notes, endogenous depression, anxiety.
Right.
I said to her, I have to put these on the sheet because, you know, they're in the notes. And there's something like 6 babies up for adoption each year in New Zealand. I don't think she's going to get one of them with that in there. And she got those labels to get her a sickness benefit about 4 or 5 years ago. Now she's done some study and she's working and everything's going quite well in her life. But those labels are no longer true, but they're still in the notes and they're still defining her, if you like. So that's the first thing. The second thing is what to do about treatment. I'm very much in favour of talk first, prescribe later. I think in primary care, there's very little reason to give medication, certainly long-term medication like an antidepressant, anti-anxiety medication at the first visit, again, because you're seeing people on the worst day of their lives. Exactly. And they're going to get better. And we know the medications tend to work for the more severe depression. So given time, people's mood will get better. Most people's mood gets better with time. So in terms of giving treatment, then we should hold fire. Very occasionally, if people have been trying very hard and they're going to lose their job, I will give an antidepressant at the first visit, just to sort of give a shotgun approach, all guns blazing, but that's really not optimal care. And I often say you wouldn't give insulin to a type 2 diabetic at the first visit, generally, unless they were badly out of control and you knew their condition was severe. And I'm going to present the FDA data, which, no surprises, the more severe depression, the more likely, the bigger the difference between placebo and drug. The problem with antidepressants is the placebo response is 40 to 50%. The actual true drug effect is about 5 to 20%. So the key is to try and figure out who's got the severe depression, and that's where using time as the diagnostic test is quite an important thing. And the third thing I want to talk about tomorrow is about this issue of compassion. I went to the Compassion and Healthcare Conference recently, and I learned a number of things. And I went and did some training with Paul Gilbert, who's coming to New Zealand with the Goodfellow Unit next year to do a compassion course. Just the issue of people's mood is often flat because they lack self-compassion. And one of Paul Gilbert's great lines is, ask the patient what the emotional tone of the voice in their head is. Like, how do you talk to yourself?
Right.
And I've started asking patients that, and very interesting in teenagers. I had one 17-year-old boy say to me, I say to myself, I'm a piece of shit. And I sort of said, well, if you're saying that to yourself, no wonder you're anxious. That's a pretty terrible way to talk to yourself. Could you talk to your mother that way? He said, no, I couldn't say that to my mother, but I could say it to myself. Interesting comment on human beings, that we can say dreadful things to ourselves that we would not think of saying to somebody else.
And teenagers are in a whole world of their own as well.
Well, and they do it to each other. They do it to each other, you know, that... Anyway, so the other line of Paul Gilbert's I really like is the the task of the adult is to learn to cultivate the voice of self-kindness in themselves. And I found that a very powerful line for patients. And I say I've had to learn self-compassion myself, just so they don't think I've got it all together. You know, I too am a suffering human being. And I say how much that helps me. You know, I'm just getting a bit steamed up in the traffic. I just say, cultivate the voice of self-kindness in your head. It just turns off my adrenal glands, and the cortisol goes down, the adrenaline goes down, and I just feel a hell of a lot better.
Yeah.
You know, it's this sort of instant peace. It's sort of like a mantra. I mean, there's many ways of doing that. But yeah, so 3 things. So avoid the labels, avoid the drugs at the first visit, keep the drugs for the severe patient,
Yeah.
and let time be the diagnosis. They're still flat as a pancake 3 or 4 weeks later. Talk about antidepressants. And I say that to patients at the first visit. Let's see how you go. Because most people get better at the second visit because they've had the reframing, the hope, the discussion, the love, the caring that their health professional gives them. And so they will be a lot better next time. And they can see that, and getting people to exercise, that's the other thing. So that would be good, yeah.
And obviously you've been working in the field for quite some time, and I understand you've done a lot of research on the field. Have you found, you know, there's been a lot of mass media towards making mental health issues more open and more aware. Have you found that there has been a change in, you know, more people coming in to seek help because of this?
Well, very much so. I think the John Kirwan thing has been absolutely fabulous. I can remember 20 years ago, a depressed man who was in his 40s coming in, and he kept wanting more tests. He said, no, I just feel physically ill, which of course he will, because somebody with a major depression has the quality of life of somebody on renal dialysis. So people feel physically ill, but actually it was a psychological problem. And he eventually saw a psychiatrist and got better. I don't think he believed me. But the John Kirwan thing has made it very much... women have always been okay with mood problems, but men, it's made a huge difference for men. But also I get them to fill out a depression inventory. I use the PHQ-9, and I find that helps because they've filled it out themselves. I say, your score suggests you've got a mood problem. I don't say depression, I just say a low mood.
Yeah.
I avoid the label depression.
Yeah.
I mean, once upon a time I thought I was quite good at diagnosing depression and anxiety. I honestly can't tell the difference very often, and actually it doesn't matter. You look, I'm more interested in the functional deficit. So what I do is a thing called a work-love-play sheet. It looks at somebody's, how their life is going in terms of their work or school, lovers and friends, lovers and intimates, lovers and family, play, and then I ask them some questions about lifestyle. And in under 5 minutes, I get a snapshot of their life. That form is available on my website, which is brucearroll.com. It's all free. And there's always points of action from that. Somebody who's distressed always has what I call a sawtooth pattern, or very occasionally all their scores on a 1 to 10 scale are down here, a very flat human being. And you can always see what's missing in someone's life. It's just absolute, there's 1 to 10 to 15 things on that sheet which you can get them doing. Because what people do when they're distressed, they stop doing helpful things to themselves, like exercising and keeping in touch with their friends, and they start doing things which aren't good for them. Drinking more alcohol, smoking more cannabis, not exercising, spending more time in bed. All things which add to your demotivated state. So you've got to stop them doing the things that don't work and get them back to doing the things that have worked and help them with their lives. So that's a work-love-play form. It's very sensitive, 98% sensitive. So if somebody's doesn't score less than 35 on that, they haven't got a distress problem, but it's very helpful. So rather than a diagnosis, you get a functional assessment of the patient, how they're functioning, where they're not functioning. And that's really what you want to know in primary care. Fix the non-functioning and they'll probably start getting better.
Well, thank you very much for talking to us.